Hi, everybody. Thank you for joining this evening in what should be a really exciting and interesting lecture. The lecture itself will start in just a couple minutes after we allow more of the attendees to log on. I think you're going to find it a fascinating presentation tonight on OCT angiography applications and interpretation by Dr. Nate Lighthizer. Nate, welcome.
Well, glad to be here, Craig. Thanks for having me.
This should be really a lot of fun. I'm Craig Norman. I get the honor of being the moderator for tonight. And we're going to have a series of things that are going to happen. We're going to have the presentation. There's going to be some polling questions. We are going to have the opportunity for you to stick around a little bit at the end to learn more about one of the devices in this category. And I think you'll find tonight really well worth your investment of time. So let me introduce, if I can, Dr. Lighthizer. He's got an unbelievable resume, and we'll try to get through this. He's born in North Dakota, a graduate of Pacific University, and completed a residency in family practice with an emphasis on ocular disease at Northeastern State University, which is in Tahlequah. Dr. Lighthizer has since joined the faculty of that school, and he serves as chief of the specialty care clinics and chief of electrodiagnostic clinic as well. And about 10 years ago, a little less than 10 years ago, we founded and now heads the dry eye clinic at the College of Optometry as well. In 2014, he was named Director of Continuing Education, as well as the Assistant Dean for Clinical Care Services at the College of Optometry there. Starting in 2020, he was named the Associate Dean of NSU, and he's a founding member and currently serves as president of the Intrepid Eye Society, which is really a terrific group of emerging thought leaders in optometry. He was named a member of the PCON 250, a list of the top 250 optometrists in the country who practice progressively, provide innovative optometrists in the country, and that are involved in patient care, optometric research in academia, and share that information, as you'll find out tonight, with other optometrists. Dr. Lighthizer lectures nationally and internationally on numerous topics, most notably advanced ophthalmic procedures such as electrodiagnostics and ocular disease. His financial disclosures you will see there. And all of these financial relationships have been mitigated, so we're all cool with that as well. So with that being said, Nate, we're really interested in having this information tonight, and why don't you go ahead and take over?
All right. Thanks, Craig. Appreciate it. Good evening, everybody. Hope you all are doing well. Excited to have all 940 of you tonight on our webinar on OCT and more specifically OCT angiography. So we've got a lot to cover in the next 45 to 50 minutes. So I'm going to go through this fairly quickly. We're going to answer your questions at the end. And again, really talking on OCT angiography. That's the nature of this lecture. That's the topic of this lecture. The title of this lecture is OCT-A. And I'm going to poll the audience. If you guys have been to my lectures before, you know I like to poll the audience. And I know we're not live in person, but we are live virtually. So I want everybody to grab their phone or their tablet, or you can open a browser. I do want to emphasize this is not required. You will still get your CE credits even if you don't do this, but it's a nice, fun way to kind of see what the group is thinking. There's no individual answers. This is completely anonymous. So open up a browser, open up Safari, open up Google Chrome, and type in pollev.com/Nate Lighthizer. That will bring up my Poll Everywhere page. Again, I'm going to ask you a variety of questions throughout the next 50 minutes. What do you think the diagnosis is? Are you concerned with this patient? Yes or no? And nobody likes to raise their hand. Obviously, we're virtually, but this is a completely anonymous way to poll the audience. Again, this is not required. I say again, it is not required. You will still get your CE credit. It's just encouraged. Have a little fun with this. You don't have to download anything. You don't have to sign up for anything. Again, just open up Google Chrome, open up Safari, whatever your browser is, and type in pollev.com/Nate Lighthizer. And again, I'm going to probably ask you 5, 6, 7 questions throughout the course of the next 45 minutes. Again, completely anonymous. And one more time, you do not, I repeat, you do not have to do this. It's not required. You still will get your credit even if you don't do it. But again, recommended. Let's have some fun with this. So my first question is, do you have OCT angiography in your practice? Yes, I do. Or no, I don't. Great. We've already had about 130 people respond. So we'll get a nice kind of smattering of answers here. Just wanted to open it up. Obviously, no right or wrong answer on this one. And again, if you joined late, this is not required. You can scan the QR code in the top right or join by the web, thepolev.com/Nate Lighthizer. And then I hit a button and look at that. Awesome. So 37% of you have OCT angiography, a little over a third. That is the highest percentage that I've ever seen before. That is awesome. Usually when I ask this question, it's between about 5 and 15%. Obviously, many of you are interested in OCT angiography, so let's get down to business here. It's certainly a technology that has emerged over the course of the last 3, 4, 5, 6 years. We got our OCT angiography, our OCT instrument, the Avante, back in 2016. So hard to believe we've had it for almost 7 years, a little over 7 years now. And it really, it's the next step in OCT imaging. We had time domain and then spectral domain, and then OCT angiography comes about in 2014. The ability to image the retinal microvasculature, the optic disc, peripapillary microvasculature as well. Just a really cool way to be able to see those blood vessels in a state that we normally couldn't before then. So again, I don't know if you call it structure and function, probably not the right term there, but the point is be able to image the vasculature, capillaries, capillary dropout, neovascularization, choroidal neovascularization, to be able to see blood vessels that we couldn't see with the naked eye without having to do a fluorescein angiogram. I think that's the benefits, is we're reducing the patient burden, more frequent imaging. We're not doing an injection in the arm, fluorescein injection, potential side effects, anaphylaxis with those, even though it's very, very rare. It's just much faster to be able to get an OCT angiography compared to a fluorescein angiogram. So it's really revolutionized how we look at the vasculature for the retina and the optic nerve. So how does this work? Well, it uses motion contrast. The scan is going to take a little bit longer to scan that retina, that macula, that optic nerve than a traditional regular macular OCT. It's looking at motion contrast, sequential B scans. And the only thing that should move from scan to scan to scan to scan to scan to scan is obviously red blood cells inside the vasculature. So anything that it detects that's moving, it says, aha, that must be red blood cells inside a blood vessel, and therefore the algorithm then knows where those blood vessels are at. So motion contrast, multiple B scans, overlay the top, and flow is the difference between the two. So how does it do this? There's so many different ways to visualize an OCT. I want to encourage you to look at the on-FOSS OCT, which is different slab by slab by slab by slab. Let me give you an example. If you look at me here, here's you're looking at a notepad here, and you can see the top layer. But if we peel that away, now you can see the second layer, and you peel that away and you can see a little bit deeper, and you peel that away and you can see a little bit deeper. That's what on-FOSS imaging does. And you can see layer by layer by layer by layer, superficial capillary plexus, deep capillary plexus, the outer retinal zone, which is largely avascular, and lastly, the choriocapillaris. You can see what's going on in these different layer by layer by layer. Let me give you an example. This case has nothing to do with OCT angiography, but just looking at different cases, different OCTs in different ways. This was a 60-year-old female referred in from a retina specialist. You heard Craig say I'm the chief of our electrodiagnostics clinic, or I was the chief of our electrodiagnostics clinic, referred in for a VEP and an ERG. Vision's down. Retina specialists can't figure out why the vision is down. Is this neurological? Is it not? Do we need neuroimaging, MRI? Do we not? Sent in for some electrodiagnostics testing. Here's the OCTs. And this patient's got a mild epiretinal membrane. You can clearly see a mild ERM in both eyes, but I wouldn't think that ERM is reducing vision down to the level of 20/60, go back into that right eye. I mean, if you showed me this OCT, I'd say I wouldn't be surprised if their vision was somewhere between 2020 and 2025. But, and again, here's the 21 line raster, same thing. But notice when you look at this in a little bit different way, when you've got the en-face imaging, and again, this is not OCT angiography, but just introducing the concept of en-face imaging. There's the internal limiting membrane, the interplexiform layer, the RPE, and lastly, the choroid there. Look at the diffuse nature, the area that this epiretinal membrane covers. You couldn't really appreciate how expansive this ERM was when you were looking at it here or there, going, I don't know if their vision would be down for that. Now you can really see when you look at these pictures, these OCTs in just a little bit different way with en-face imaging, you can really highlight different features in the retina. Again, this is not OCT angiography, but just showing you how the en-face imaging works. This is how OCT-A works. These OCT-A slabs, superficial capillary plexus, deep capillary plexus, the outer retinal zone, which is avascular. And therefore, when it's avascular, it should be dark. We're going to come back to this a lot when we talk about macular degeneration here in just a few minutes. If you're scanning a patient with dry AMD, hopefully this outer retinal zone is dark. You are not picking up any anomalous blood vessels, any abnormal blood vessels. That would be signs of a choroidal neovascular membrane. And then lastly, the choriocapillaris. So notice slice by slice by slice by slice, and we'll go through these in just a little bit there. So again, there's another picture. I'll come back to this in just a second here. So, you can't know what abnormal is until you know what normal is. So what is normal? And I'm starting way back when we first got OCT angiography in 2015, 16, 17, 18, we had these just fascinating pictures. And you take a look at this, and this is an OCT-A scan of the macula on a healthy 25-year-old optometry student. Notice we have no numbers in this scan. This is qualitative data, and it's beautiful data. We can see these capillaries. We can see the foveal avascular zone, nice and regular here, looks great. We've got the superficial capillary plexus, the deep capillary plexus, the avascular outer retina, and lastly, the choriocapillaris. Looks awesome. This is completely normal. But again, this was the qualitative data. And this was nice to start, but don't you want numbers? I want numbers as well. When you guys look at OCTs in glaucoma, we look at the reference database and the normative database and where do they fall, but we all look at those numbers. What's the retinal nerve fiber layer? What's the numbers in the quadrants and and we're always looking at those numbers. It's nice to have qualitative, which you're seeing here, but we want to see numbers. And now we have that, and we've had that for quite some time now. So there is normal. There's the superficial capillary plexus. There is one layer deeper, the deep capillary plexus. You go one step deeper and we're in the outer retina. There's that black area, no vessels, no vasculature. There should be no flow on this area. And lastly, the choriocapillaris, or the choroid right down there. So that is very normal. So what is the indications in this? And I'm going to show you, we're going to go through the indications of each of these scans here, each of these conditions in just a second. So we're going to start with AMD, the dry versus wet AMD. Maybe the flashiest, maybe the most useful. And that diabetes is pretty darn useful as well. But we're going to start with AMD. We're going to quickly cover glaucoma, and then we're going to finish with diabetes as well. So about 10, 15 minutes on each one of these. But I'm going to start with, I think, is maybe the most useful, most flashy, the sexiest way to use OCT angiography is for macular degeneration. So let me show you a quick case. This was a 71-year-old Native American female referred in for a macular OCT. What's going on in this macula in the left eye? Vision's down. Vision is 20/70, as you can see in the left eye. And isn't this our job often in retina? As optometrists, we treat red eyes, we treat conjunctivitis, we treat corneal ulcers, we treat blepharitis, we treat dry eye, we treat a lot of anterior segment stuff. We prescribe a drop, we prescribe an oral medication, whatever it is. But we handle the anterior segment stuff. When it comes to posterior segment stuff, we may handle that as well. Cystoid macular edema, treat them with a topical steroid, topical NSAID maybe. But generally speaking, very generally speaking, isn't this kind of our job when it comes to retina? When it comes to diabetic retinopathy, macular degeneration, vein occlusions, whatever it is, am I going to, I'm looking at this patient, am I going to watch this and just observe and educate and follow closely? or am I going to send this to our retina specialist? This is a lot of times what our decision is not whether I'm going to treat or not. Am I going to refer this, or am I going to hold on to this and closely observe that? And I think OCT angiography helps us so very much. Here's why. I think this is an important point, and I'm going to get to this in just a second here. So this patient was 20/70 in this left eye. We've got an Amsler grid defect. There are the back of the right eye and the back of the left eye. Again, 20/20 in the right eye, 20/70 in the left eye. So vision's down in the left eye, Amsler grid defect. Here is the OCT. And again, I've got a little magnifier here that actually works on this. So you can see right eye looks great, perfect, nice. That's the 20/20 eye. You come over to the left eye, and we certainly have an area in question right here. I'll give you a couple of seconds to kind of digest that right there. There's the, again, OCT. So my question for you is this, very quickly, quick answer on this one. Go back to your phone or your tablet. Concerned or not concerned about this 71-year-old female? Let's let those answers continue to come in. You guys can continue to answer while, again, I show you the OCTs. Again, I haven't showed you the OCT angiography yet. Back to the photos. 20/70 in this problematic left eye. There's the left eye. I'll give you the OCT one more time. There's the OCTs right and left. And you know what? If you said on this one, Nate, I don't even think I need an OCT angiogram. I'm pretty concerned on this one. Yeah, I would completely agree on this one. That you take a look here, and you can clearly see not only do we have some elevation, a suspicious, probably choroidal neovascular membrane, leaking some subretinal fluid on this one as well. So I think you could probably get by with the without the OCT angiogram with just an OCT on this one. But I throw this case in because, yeah, you guys are concerned, so am I. And I'm concerned based on that OCT. And here is the OCT angiogram of the right eye. Looks perfect. Again, this is the 20/20 eye. I'm not concerned about this one. And here's the OCT angiogram of the left eye. And take a look at this great big membrane right there. Again, I want to see a completely, if we go back, there's the normal eye, nice and perfect and no membranes there. It's nice and black in the right eye. And this eye, again, has a humongous choroidal neovascular membrane. Again, I think you could have got by without OCT-A. So nice to be able to image these fluid. But to me, here's the middle neovascular membranes one step sooner. Before they're leaking fluid subretinally, before they're leaking fluid intraretinally, to be able to image that. Yes, in this case, it's already leaked fluid, so we're a little bit later on that. But boy, what an image there of that choroidal neovascular membrane right there. And again, you can go slab by slab. There's a nice big look at that outer retinal zone showing that membrane, and in the choriocapillaris as well. So absolutely easy one to see right there. Here's another one. Case number 2, 63-year-old male. Referred in for OCT due to vision changes, where vision's down a couple of lines in the left eye. 20/40 -2 in the left eye, 20/20 minus in the right eye. There's the back of the right eye. And the back of the left eye. Back of the right eye, back of the left eye. And OCTs, a little bit different picture than the OCT in the last case, where it was pretty obvious. We had a lot of suspicion going on here. Again, we're 20/20 minus in the right eye, 20/40 in the left eye. Take a look at these retina maps here. They look pretty darn good. You take a look at these 21-line rasters. Shoot, they look pretty darn good here as well. Again, quickly, I'm going to ask you the question, same question as before. Concerned? Not concerned about this one. Again, there are no wrong answers here. I just want to poll the audience. Let's get 100 of you answering in this 63-year-old male. No wrong answers. Concerned, slightly concerned, not concerned at all. Again, looking, there's the OCT one more time. There's, again, the OCT. Again, referred in for vision changes. Back of the left eye, back of the right eye. Again, would you refer? Would you hold on to this? I think this one, I'm guessing we're not going to have as many concerned on this one. Last time it was 85%. Now we're on the fence. You ever been on the fence in retina or glaucoma or whatever it is? Boy, it'd be nice to have that OCT angiogram. We don't have any subretinal fluid. We don't have any intraretinal fluid based on the OCTs. Do we have any membranes? Take a look at the 2020 eye, and you look closely, and we see the presence of what I think is a subtle, early choroidal neovascular membrane in that outer retinal area and that choriocapillaris area right there as well. Left eye, if the vision was down, maybe, maybe not. Does this mean you're going to refer to retina? Maybe. Maybe not, depending on your retina specialist, where you practice. Again, there's no fluid yet. I would lean probably towards a referral, but you need to work with your retina on that. I wouldn't fight you if you said, you know what, I'm going to hold on to this very closely, watch this very closely. You know you're going to educate this patient even better because you're seeing the presence of that membrane that we just showed you right there. Again, imaging a problem one step sooner than we saw it before. Here's another case, 71-year-old female. And this patient referred in for an OCT for glaucoma and AMD, 2030, 2040. When I saw the patient, there's the back of the right eye. Here's the back of the left eye. So we definitely have some pigmentary changes in this patient. OCTs, definitely some kind of widespread thinning. OCTs of these retina maps right here. There's the right eye. There's the 21-line raster in both eyes. Let me kind of blow up that right eye a little bit. And I'm not seeing any subretinal fluid at this point. I'm not seeing any intraretinal fluid at this point. One more, same question, different case. Concerned, slightly concerned, not concerned in this patient here. Let me go back. You guys can continue to answer. Let's go back, show you that one more time. How old? 71. Yep, 71-year-old female, 2030-ish. Back of the right, back of the left. OCTs. Again, if you joined late, the polling is not required. There's your 21-line rasters in both eyes. Let's see. Are you guys concerned or are you not concerned? Let's see here. Love the responses. All right. Yeah. So 44% of you are concerned, 48% slightly concerned. I agree. This is kind of in between those last two cases. I just loved this case and being able to image right eye 2030. And I mean, this looks suspicious to me. When I'm taking a look at this OCT, yes, there's no fluid there, but man, that looks suspicious right in this area. No fluid yet. And boom, look at that membrane right there, a choroidal neovascular membrane. Again, we've picked that up one level sooner, one step sooner, and we can get this patient to retina a little bit quicker for treatment, fluorescein, injection, et cetera, et cetera. And we all know earlier treatment tends to give better prognosis and better results, whether it's in eye care or other conditions as well. Classic choroidal neovascular membrane right there. So again, I showed you 3 cases in a row of membrane, 3 in a row. Again, I go back to, should I refer, should I watch this? I will tell you many more times than not, it comes back like this. And you've got a patient that clearly has got dry macular degeneration. We've got some outer retinal changes, some drusenoid changes there. It doesn't appear based on the OCT that we have got any fluid, no intraretinal fluid, no subretinal fluid. I'm not overly concerned based on this scan right here, but then I've got the OCT angiogram. And again, I'm looking at this plot right here and right there. And again, I'm not seeing any vessels here in the right eye or here in the left eye as well. So many more times than not, 9 times out of 10, we do an OCT angiogram and it makes me feel better. It going, okay, good. No signs of any CNVM here. I can reassure this patient, makes me feel better. Use your Amsler. I'll see you back in 6 months versus I'll see you back in 3 months or 2 months, or I'm referring to retina if I pick up a membrane. So this makes me feel better. And this is usually what the case is in that one. Last case of AMD, 2-year history of AMD, slight vision changes in the left eye. Again, we're 2020 and 2025, pretty good vision at this point. Back of the right eye, 62-year-old, back of the right eye, and back of the left eye right here. Again, I don't see any blood. I don't see any, based on the photos here, anything that's overly suspicious. OCTs. In both, there's the OCT, the right eye, there's the 21 line raster, and OCT of the left eye. Again, we've got some outer retinal changes, some drusenoid changes here. And again, I'll ask you last question on this very quickly. Concerned, slightly concerned, not concerned in this 62-year-old female. Or was it male? I can't remember. 62-year-old female. 62-year-old female. Yep, 62-year-old female. Again, 20/20 right eye, 20/25 left eye. Real quickly, back of the right eye, back of the left eye. OCT of the right, OCT of the left. If I just gave you this info, what do you think? And again, I would agree on that. You know, it looks pretty good. I would lean toward, never wrong to be slightly concerned, is it? But more of you not concerned versus concerned. Let's get an OCT angiogram. Right eye looks great. I don't see any presence of any CNVMs right here or there. It looks good. But in that left eye, if you look closely, and I'm going to magnify it just a little bit, is this a little subtle spot right there, a little choroidal neovascular membrane? Go back to this. You can see it on the regular scan. Again, I don't know that I would refer this patient to retina, but I would be watching this very, very closely at this point, and I wouldn't fault you for referring that to retina as well. So macular degeneration, use it. It's going to come back dry, way more than wet, but utilize it in macular degeneration to help you determine how concerned am I? Do I need to refer? How closely do I need to watch? Et cetera, et cetera. How about glaucoma? Glaucoma in about 5 to 7 minutes here. I'm going to start and finish with this. We are still in our infancy of utilizing OCT angiography in glaucoma. Do I utilize this in every single glaucoma patient? I don't at this point, but it's becoming more and more and more common to be able to image the peripapillary vasculature. And again, we now have printouts that look like this. And I'm going to go through a quick case right here. 61-year-old male. You know, we've got better and better OCTs. We just got a brand new OCT angiography in our clinic. I was part of the clinical trials of the reference database and the normative database and the repeatability studies, and just a phenomenal device. 61-year-old male, diagnosed with glaucoma in 2016, right eye more than the left eye, started on a prostaglandin, had an SLT. Again, I know we're not talking about glaucoma tonight. No care from 2017 to 2021. And you go, oh, you know, diagnosed with glaucoma, then you go 4 years without an exam. I see him in August 2021. He's 20/25 minus in both eyes. There's the pressure history. Give you a couple of seconds to digest that pressure history. Again, low to mid 20s, right eye higher than the left eye. Got him down into the mid teens. Thank you, SLT, for holding on without no care from 2017 to 2021. You know he's not taking his drops. Thank you, SLT. And when I saw him on August 31st, 2021, pressure was actually reasonably good in that eye. Grade 1 nuclear sclerotic cataracts. There is the right eye, back of the right eye. Significant cupping in the back of that right eye. I called this about a 0.885 vertically by about a 0.657 horizontally is what I called this right eye. Definitely some asymmetry when you look at the two pictures of the left eye. Let me put both of them on the same screen here. Definitely we have some asymmetry with the right cup much bigger than the left cup. Don't forget about gonioscopy in these cases to rule out secondary glaucomas, but definitely some asymmetry with the right cupping worse than the left. Here's the visual fields. Ooh. And visual field much worse in the right eye compared to the left eye. Give you a couple of seconds to digest that. All right. Good news is that he had a visual field in early 2017, and it's not good that he had significant visual field defects by then, but he hasn't shown much progression from February of 2017 to September of 2021 when I saw him on the second visit, but still significant visual field defects. Based on visual field criteria, I would call this severe glaucoma in this eye. Here was one of his OCTs that I did, and again, you can see the significant overall nerve fiber layer right there, RNFL analysis, right eye, and left eye. Notice the significant difference right there, as well as the ganglion cells. There's your T-SNP curve right there. And then again, our newest printout, just love this printout to be able to have everything, kind of a one-stop shop on this. This is one of his recent scans. And you take a look, and I'm going to again go to different areas here. This OCT device now has fundus camera in it. So we've got a fundus camera where you can take photos. There's the right eye, there's the left eye, right in the printout. And we have got the retinal nerve fiber layer with the deviation map right there. Okay, and I forgot to check the reference. I love that you have so many options here that you can manipulate your printouts to how you would like them. Normally, I have this reference database box checked, and then it turns this area green, yellow, or red. That's why there's no colors there, because I don't have the box checked. Normally I do, but there's your retinal nerve fiber layer in the right eye, retinal nerve fiber layer in the left eye, ganglion cell analysis with the deviation map on. You can see I have deviation map checked, and you can see we have minimal to no deviation from normal in the left eye and severe deviation from normal in the right eye. And then we have our OCT angiogram as well. So we've got everything built in. We've got OCT, the nerve fiber layer, ganglion cell analysis, OCT angiography of the nerve, and we've got fundus photos in here as well. And then in the middle, you've got all your numbers. Again, great to have pictures, but I want my table analysis as well. There's the retinal nerve fiber layer. Notice the big asymmetry between right eye and left eye, your optic nerve head analysis, cup to disc ratio, ganglion cell numbers right there. And then lastly, your vessels around the optic nerve. So you've got everything, kind of a one-stop shop on this printout. Awesome to be able to have that in this particular patient there. So this patient obviously, so you can customize this. This is with the angio view. So I'm including the OCT angiograms. Here I took it off just to give you another printout to look at. Still has everything the same that I showed you before. We've got fundus photos right here. There's your nerve fiber layer analysis. So in the deviation, there it is right there as well. Again, I don't have the RDB, the reference database, checked. Otherwise, there would be colors around this circle, ganglion cell deviation, and all your numbers in the table as well. So again, I think this is going to be very, very interesting going forward as we learn more and more and more on glaucoma and we utilize OCT angiography. You know, you can tell if you look at this patient, and I know his nerve fiber layer is way thinner in the right eye compared to the left eye, and his ganglion cells are way thinner in the right eye compared to the left eye. And notice that his vessels, he's also showing defects in his right eye more so than the left eye. Is glaucoma a vascular disease? In part, yes. And, you know, do the vessels go before the nerve fiber layer? Does the nerve fiber layer go before the vessels? I think there's contradicting studies at this point, and we're still trying to figure that out. But you can clearly see the more diseased eye has a less retinal capillary density. You can see overall there, look at those numbers, much stronger in the left eye compared to the right eye. So we're going to only continue to learn more about OCT and OCT angiography specifically in glaucoma in this particular case. And then again, just showing you the retina view. I did a retina scans on him as well. Again, we've got glaucoma, optic nerve condition, optic nerve disease, but don't forget about the retina, which we're going to cover next in our diabetes and diabetic patients. And again, you're taking a look at the superficial capillary plexus in the right eye and the superficial capillary plexus in the left eye. And again, notice we have more than just the qualitative data. We started with no numbers. Now we've got numbers. Now we've got tables. Now we've got the measuring the foveolae vascular zone, which we'll cover here in just a little bit. What's the perimeter of the foveolae vascular zone? As that FAZ is getting bigger and bigger and more irregular, that may be a sign that your diabetic patient is progressing. This patient that had glaucoma also has diabetes as well. So you're looking at a nice angio view of the retina in this particular case as well. So again, and then you obviously have corneal maps. We do corneal maps. We've got the pachymetry to see what their central corneal thickness is, corneal thickness in other parts of the cornea. And again, we talked about the fundus photos as well there. So again, I'm not going to go through all this glaucoma stuff. This is not a glaucoma lecture at this point, but just wanted to show you again in 5 to 7 minutes of glaucoma. Are we utilizing OCT angiography in glaucoma more and more and more? Is it standard of care at this point? No, but I think within the next few years, 5 to 10 years, we're going to look back on, how did we manage glaucoma without an OCT? Today we sit that and go, man, it'd be hard to manage glaucoma without an OCT. I think 10 years from now, we're going to look back and going, got to have that OCT angiography to look at that peripapillary, that retinal plexus. What's the capillary network around the nerve? Any thinning, any early thinning? Maybe we pull the trigger on a glaucoma diagnosis early. All right, in my last 15 minutes, I want to make sure we hit, excuse me, diabetes.
How long?
Second most common reason that I do an OCT angiogram. Macular degeneration is number one, and diabetes is right behind there at number two. And why is this important? Are you seeing more and more or less and less diabetes in your practice? And the answer is more and more and more. And we're just seeing more and more of this. And we know it's only going to increase over the course of the next 5, 10, 15, 20 years. The rates of retinopathy, there they are, the rates of progression. Your patients that have no retinopathy, within 1 year, 5 to 10% will have retinopathy. If they've got mild, 16% or 1 out of 6 patients will have proliferative in 4 years, which means they went from mild to moderate to severe non-proliferative on to proliferative. How much macular ischemia do they have? How much retinal ischemia do they have? How much capillary dropout, etc.? The more capillary dropout they have, the more ischemia they're likely to have, and the more quickly they are likely to progress through the stages of diabetic retinopathy. So we know we need to look at this quickly, or closely, I should say. You're still going to take your fundus photos. You're still going to do your DFE. You're still going to do your OCT. This doesn't replace any of that. Still take your photos, still bill for your photos, document that, do your OCT, but your OCT angiogram has a big, big part of that. Diabetic macular edema. Remember, it can go both ways. The macula can go both ways. We all think of this, the diabetic macular edema, but don't forget about that. The macular ischemia. The retina is thinning. It's not thick. It's not swollen. It's not edematous, but it's thinning. And you need to do an OCT angiogram, and diabetic macular ischemia has been shown to predict diabetic retinopathy progression. 41% of patients with diabetic retinopathy had some degree of macular ischemia. That can be tied to vision loss. If they have moderate to severe macular ischemia, that can reduce VA. If we can catch it at the mild stage, the earlier stage, normal VA, maybe we can intervene, educate our patient, maybe a diabetic supplement, and maybe they can jump on this sooner. So what are the advantages of OCT-A? Obviously, we can identify earlier stages of diabetic retinopathy before other technologies can, before they're leaking fluid, before they have edema, capillary dropout, enlargement of the foveolae vascular zone, less invasive, quick acquisition time. You can look at multiple layers of the retina. Remember those en-face images? Slice, slice, slice. The superficial capillary plexus, the deep capillary plexus, that's where I'm looking with OCT angiogram. Localize MAs to their exact retinal depth. Again, lots of advantages. What am I looking at in diabetes? Well, in diabetes, I am looking, and I've mentioned it a couple of times already, look at that foveal avascular zone. I'm going to show you pictures of that in just a second. Study after study after study now shows that enlargement of the foveal avascular zone on OCT angiography. You can't see it with your fundus photos, can you? You can't see the FAZ with the naked eye, but on OCT angiography, yes, you could see it with fluorescein, more invasive, probably sending it out of your practice. But with OCT-A, you can see that foveal avascular zone, and studies have shown when you start seeing that become bigger and more irregular. Again, you don't want your foveal avascular zone to get bigger and bigger and bigger and bigger. That means you have capillary dropout. Things are becoming more irregular, and that can be a sign of early diabetic retinopathy before they have MAs, before they have cotton wool spots, before they have hemorrhages. Watch the size and the perimeter, the irregularity of that foveal avascular zone. And also look at those capillaries. That capillary network in the various areas of the macula, superior, inferior, nasal, temporal. Look at those capillary dropout. Assessment of capillary dropout in the superficial retinal capillary plexus in the early stages of diabetic retinopathy. This has been shown to correlate in an inverse relationship to macular thickness. What do I mean by that? As the superficial capillary network decreases, as that vessel density increases in the superficial capillary network, retinal thickness has a tendency to increase. And you know what happens when retinal thickness increases. That's macular edema, that's swelling, that's decreased VA, and likely needing treatment as well. So as the vessel density is going down, macular thickness has a tendency to go up. They are inversely related on that. So take a look at these scans. Perfect, normal, healthy optometry student. Looks great. There's the superficial capillary plexus. There's the deep capillary plexus. Again, I hope it looks like this, not that. And now you can see it's getting bigger. Obviously, we have no numbers here. So this was in the early days of just, we've got a picture and we kind of had to judge, is it getting bigger? Is it getting more irregular? It's pretty obvious in this. Now we have the tools and the software that measure the exact area of the FAZ, measure the exact perimeter of the FAZ, and you can compare this over time. Is this getting bigger? I hope not. I hope the FAZ is not getting bigger over time. The deep capillary plexus, again, becoming more irregular. The perimeter is getting bigger. The area is getting bigger as well. That is going to be a concern. And again, measure this visit after visit after visit after visit. And I may follow a patient more closely. I may start them on a diabetic supplement, may have maybe an earlier referral, more strict education, refer them to the PCP. If you are seeing progression in the size of that FAZ, that is concerning in these patients. And again, there's trend analysis now. Again, you can take a look at these visit after, just like in glaucoma. You guys all do that with your retinal nerve fibrillator, with your ganglion cell analysis. You look at progression analysis, and we can do that with the FAZ area, the FAZ perimeter, et cetera, et cetera. So, and again, we look at the capillary non-perfusion as well there. So take a look at the FAZ, take a look at the capillaries. Again, I put this slide up here just to emphasize one more time. Remember when we talked about AMD? Again, our kind of four main slices, our en-face slices through the retina. And when we were focused on the outer retina, AMD, looking for choroidal neovascular membranes, I was focused on the outer retinal slab and the choriocapillaris slab. I didn't care as much about these two slabs in a macular degeneration patient unless they have diabetic retinopathy. Now we've changed the game. We're now talking about diabetes and diabetic retinopathy, a retinal vascular disease. And now I'm more concerned about these two slabs, the superficial capillary plexus and the deep capillary plexus. Less concerned about these because they're not going to grow a choroidal neovascular membrane in diabetes and diabetic retinopathy. So take a look at that capillary network. Again, this is qualitative. Now we have quantitative analysis as well. Does require a little longer fixation than fluorescein. What do I mean by that? A fluorescein angiogram, once you've injected the dye and they're in the camera, it's just a click to get the picture, versus an OCT angiogram can take a period of seconds to be able to get that. So they do need to fixate. If they are moving their eye all around, you're not going to get good scans on an OCT angiogram. So a lot of advantages with this. What's normal? There it is. Looks great. Again, no metrics at this point, no analytics at this point when this scan was taken. This scan is like 6-7 years old. We now have wonderful analytics here. Looks perfect. Looks great. Diabetic patient. This is a normal patient, I should say. And notice what changes between this and this. Your FAZ has become much bigger, much bigger compared to this one. And you can see the irregularity. You can start to see some of the capillary dropout in that area. Again, FAZ is bigger. Follow these over time, looking for capillary remodeling, capillary dropout. That can be a concern and can present before hemorrhages, cotton wool spots, et cetera, et cetera. Let me show you a long-standing 30-year diabetic case. This was a patient that I had saw, and he's been, again, diabetic for close to 40 years. He's got close to proliferative retinopathy, not proliferative at this point, but you can see he has almost no capillary network left. The chances of him progressing and progressing quickly, I mean, there's no capillary. Compare that again, go back to the normal case. Look at all of these capillaries in the superficial capillary network and the deep capillary network. Great in a healthy optometry student. And then you go into a long-standing patient in their 80s, 30 to 40-year diabetic, and you can see those capillaries are just shot in that particular eye. Again, is there anything we can do about it? Maybe, maybe not, but educate, watch that patient closely. Branch retinal vein occlusion. Which eye did this patient have a branch retinal vein occlusion? Again, here's the right eye. Here's the left eye, and here is the right eye. And take a look. Was this vein occlusion in the right eye superior or inferior? We'll take a look. We've got not great vessels, but there's some here, but look at the capillary dropout in this area there. So just imaging beautifully the capillary loss in this patient with a hemiretinal vein occlusion inferiorly in that particular eye there. So again, lots of advantages for OCT-A in diabetes. And now we can watch it over time with, this is looking at not the foveolae vascular zone. Remember, if the FAZ gets bigger, that's a bad sign. If the capillary vessel density, this is looking at vessel density, if that is getting smaller, that's a bad thing. You are seeing capillary dropout and capillary dropout and capillary dropout. And notice it's just getting worse and worse and worse. It's best on the left. There's nice and normal. And as you're losing your vessels, getting thinner and thinner and thinner right there. And now we have analytics, which is just beautiful to have analytics. Again, it's great to have this image. 7-8 years ago, it was spectacular. I remember the first time I saw it, I went, wow, look at this. So cool to be able to image the vessels. But there's no numbers. Now we have numbers. Now we have analytics. Is there flow areas that shouldn't be there? A choroidal neovascular membrane, an AMD, dry versus wet. Is there non-flow areas? Again, diabetes, vein occlusions. We just covered that. I don't want to see non-flow in a diabetic patient. I want to see flow. I want to see capillaries. I want to see a nice vessel structure. I don't want to see a foveolae vascular zone getting bigger. Here's what we talked about already. Looking at that FAZ. Is the area getting bigger? Is it stable? Great if it's stable. Is the perimeter getting bigger? Hopefully it's not. Again, vessel density maps. This is getting better and better and better to be able to image this. And again, to have numbers now. We've got the slabs, as we've talked about in depth throughout this superficial capillary network, deep capillary network, outer retina choriocapillaris. In a diabetic, I'm mainly looking at these, but now I'm looking at this. I've got numbers here. I can turn on different, I can look at this in different ways. Here's another scan. And you can take a look, and now we can measure the FAZ and what size is it? What's the perimeter? What's the vessel density? You can see that in this slide as well. And here is the beautiful printout that we talked about before, an angio view of the retina to be able to have superficial capillaries, deep capillaries, pictures of the eye. Here's all your metrics, foveolae vascular zone, vessel density, all in one printout, and you can now watch this over time. Is it progressing over time? Hopefully not. Or is it stable over time as well? So in my last, I've got about 3 or 4 minutes left. I want to quickly cover 3 cases, about a minute in each one. Case number 2, pre-diabetic. This is a she's not diabetic. She's a pre-diabetic, 20/25 plus minus. She's unhappy with her vision. My vision's blurry, doc, 20/25 plus minus. Already had cataract surgery, clear posterior capsules. There's the back of the right eye, and here's the back of the left eye. Again, she's pre-diabetic. She has not been diagnosed with diabetes. OCT looks good. You take a look at this, and if I asked you what's the visual acuity of this patient, you would probably say, just based on this OCT, it's what? Pretty darn close to 20/20. Pretty darn close to 20/20. I don't have time to open this up. Here's the OCT angiogram. And again, notice our metrics. And again, here's the color scale. And I want to see this capillary network in the greens and yellows and oranges. That's a nice, healthy capillary network. As the capillaries are dropping out into the blues there, I don't like blues appearing on this plot. Again, we look at the numbers as well. Right eye and left eye. I've got some concern in this particular patient. We have some capillary dropout in this pre-diabetic. That, along with the ERGs, which I don't have time to go into at this point, those were borderline abnormal. I referred and communicated with the PCP. This patient's A1C was 8.4, and they are a diabetic patient. They're no longer pre-diabetic. They are diabetic. And I'll ask you, and you don't have to answer this, but just silently to yourself, your patient was just diagnosed with diabetes, and their retina looks like this. And the back of their eye looks like this. When would you see them back? I would have said a year. I'll see in a year. There's no retinopathy. OCT looks good. I am not going to see them in a year with an OCT angiogram that looks like this with this degree of capillary dropout. Maybe 6 months, maybe 3 months, maybe 4 months. Another opportunity to educate and follow this patient closely over time. Next case, case number 3. This is a 48-year-old Caucasian male in for an annual diabetic exam. He thinks he's doing well. No problems, no concerns. Last A1C is 6.6. He's 20/20 in both eyes. He thinks he's doing well. He goes, yeah, I'm not having any problems with my vision. Things are well. Again, diabetic for 16 years at this point. There's the back of the right eye. And the back of the left eye. Back of the right eye, back of the left eye. OCT, the right. OCT of the left. And, you know, again, I look at this one going pretty good on this one, isn't it? Looks, I mean, I wouldn't be 20/20. Vision's 20, looks good. Are we, I know, are you concerned? Are you not concerned? Again, I'm not going to go through this here because I don't have time. I'm out of time. But here's the OCT angiogram. How does this compare to the last patient? The last patient was just diagnosed with diabetes. This is a 16-year diabetic. Generally speaking, which one are you more concerned about? The 16-year diabetic or the 1-year diabetic? Generally speaking, the 16-year diabetic. But look at that capillary network. Plush, thick, nice, awesome. And the ERG was perfect as well. I'm going to come back. I mean, again, ERG, I'm going to come back to the OCT angiogram in just a second there. But, you know, which patient are you more concerned about? This diabetic with the capillaries that look like this, 16-year diabetic, or this diabetic where their capillaries look like that? Which one are you more concerned about? Which one are you going to follow more closely? Maybe start a nutritional supplementation as well. Case number 4, last one in 1 minute. This was a 77-year-old male, type 2 diabetic, 19 years, last A1C is 8.2. Doc, my vision's down in the left eye, just a little bit. Can't quite see well in the left eye. There's the back of the right eye. A 19-year diabetic, 77-year-old male, 19-year diabetic. Couple of small MAs here and there, nothing big. 19-year diabetic, no cotton wool spots, no exudates, no venous beating, no IRMA, no neovascularization. OCT of the right eye. OCT of the left eye. OCT angiogram. There's the OCT angiogram of the right. Again, calling your attention down here and down there as well. And I'm going to finish with this. The last 3 cases. The case number 2, the newly diagnosed diabetic, the 16-year diabetic that knocked the OCT angiogram out of the park, and the 19-year diabetic. Again, a little bit better than the first one, not as good as the second one. Which one are you going to follow closely? Gives you knowledge, gives you power in this particular case there. So with that, again, this aids disease severity, disease progression. What's the FAZ? What's the size? What's the perimeter? What's the area? Watch this over time in your diabetic patients. If you are seeing this, that is going to be bad news in your diabetic patients. Look at the vessel density reports, the thickness reports, and I've covered this already right there. So with that, again, lots of indications. We talked about AMD, we talked about glaucoma, we talked about diabetes. Again, lots of indications. Utilize your OCT and your OCT angiography, and it will give you a great gauge on, do I refer, do I watch, how closely do I watch, et cetera, et cetera. Craig, I'm going to kick it back to you. I think we're in our last 5 minutes of questions.
Great. I'm going to do some rapid fire here to begin with. Do you perform the OCT scans dilated or undilated?
Yeah, it's a good question. Is it dilated or undilated? More often than not, I do it dilated, but these newer instruments, boy, they do it really well undilated as well. So the answer is both, but I would much prefer to have it dilated, especially in these pathology cases.
Okay. Does a media opacity give a false impression of capillary dropout?
Yeah, question is, does a media opacity give a false impression of capillary dropout? It depends on... it depends on the level of the media opacity. A standard 20/25, 20/30, 20/40 cataract may reduce the signal of your OCT, and it often won't give you capillary dropout, but it can just kind of give you a lower quality scan. And, I take that with a grain of salt then, because it can miss some of that. And so it could give you some capillary dropout to some degree. So I want a good quality scan. So it depends on the media opacity.
Okay. So, of course, you discussed the FAZ quite a bit. Is there a normal value for this?
Good question. I forgot to mention that, skipped through that. when we scan a bunch of normals, and we did 110 normals as part of the normative database for the FDA trials, FAZ between about a 0.15 and about a 0.25. If we go back on here again, 0.15 to 0.25 is where I kind of see the FAZ in a normal. And as we get to 0.25 to 3 and 3 to 3.5 and 3.5 to 4, you can kind of see in this slide here where it goes. So 1.5 to 2.5 is what I consider the normal range for FAZ.
Okay, great. So you talk a lot about the trend reports and the numbers. Is this a standard right now in the industry, or is this instrument specific?
It is instrument specific at this point. When you look at analytics and you look at the ability to detect progression, it is instrument specific at this point. So know your instrument well.
Okay. And the last question here is, what supplements do you give diabetics?
Yeah, it's a good question, and not the nature of the talk tonight. And there's a bunch of them out there. Highly recommend you guys look at this study, the DIV-FUS study, and this looked at a supplement called the DVS, Diabetes Vision Support. And it showed that patients had better contrast sensitivity, better color vision, better central points on their visual field. Again, there's multiple out there for fair balance. Got to be fair balance on this. This is the one that I use the most. And I encourage you guys to look at this study. Really was eye-opening to me. This is from about 8 years ago. We are well-versed on supplementation in our AMD patients, aren't we? AREDS and AREDS 2. I use nutritional supplementation in my patients with diabetes and diabetic retinopathy, specifically if they have any degree of diabetic retinopathy, if their vision is down at all, if they have an abnormal OCT-A or an abnormal flash ERG, if you guys have ERG in your practice, if they have any one of those, if they're uncontrolled diabetic, I will strongly consider nutritional supplementation.
That's terrific. So to wrap this up, do you have any closing comments at all?
Yeah, my closing comments is, utilize your technology. I know it can be overwhelming. It's overwhelming for me at the start. It's something else to learn. But the more you utilize it, the more you will appreciate it, the more you will pick up subtle pathology. Knowledge is power. Information is power. And to have that, that FAZ is getting a little bit bigger. That vessel density around the disc looks a little bit iffy. More power, more knowledge to better care for our patients.